For the, I think next presentation will be by Dr. Jabid in place of Dr. Roni Matthew. He'll be speaking on OCT guided PCI in distal left main bifurcation lesion to optimize clinical outcome. Dr. Jabid. Is there? He's not there?
No, he's not there.
As told, okay, then we move on. If he's not there, Dr. Ravindra Rao is there. George Joseph, they told in place of project. So, if it is, okay, fine. Then I think, okay, then I think we'll have more discussions about different things, and let's start with OCT, because just the other told this.
Yeah. As a beginner, what I want to know from you, it's easy to interpret. That's all right. But unfortunately, the patients where we use are diabetics. They have creatinine which is on higher side. You end up using little more contrast. So can you tell, because as a beginner, at times he says, sir, injection is not proper, and coaxiality, of course we can improve on that, but we end up using more contrast. So can you tell us, because of the shortage of time,
basically
alternative
how
to
to
contrast.
Optimize that.
Should we dilute with the half or do something else?
I can answer later if it is okay with you. If I can address that issue. You see, what I don't know. I'll ask you this question also, and this answer to this question. What we do is we use colloid. We don't use contrast, and you get equally good images. What you need is a blood-free zone, blood-free. Transiently, the vessel has to be made blood-free. So if you use colloid, which is Himaxil, if you all know, so there's dextran. So if you use that and you inject dextran the same amount as you want to use contrast, transiently the vessel will be full of dextran and there'll be no blood there, and you can image the arteries. In fact, this is published in the literature also, and then we saw, and I don't know what you are, you still using contrast, or Dr. Ziad?
Contrast. Yeah.
Contrast. Yeah. But I use dextran and I get equally good pictures, so I think that's a very important.
Yeah, that's what I want to ask.
Yes.
So,
So you should, I use dextran.
Should we go to dextron?
Yeah, I use dextran. I'm telling you.
See, I don't have any experience in
because
using
I've been
dextran.
using it for more than, I think, about at least a year I've been using dextran.
But what is the limitation of using this dextran?
There is I don't see any limitation, because dextran is Himaxil, which we have in our hospitals. Like supposing a person is bleeding and you don't have blood right away, you infuse it with dextran, because dextran is a colloid. It has a high osmolality. So otherwise, if you just give saline, the blood becomes water. It becomes dilute. So dextran is that what we use as a volume replenisher, and it's a high, it's an organic content, high molecular weight molecule. And the only difference, like what happens with contrast, if you see contrast and blood, when you mix in a syringe, it mixes very slowly. And that is what the contrast does, that transiently it will be without blood. And when you take water, saline, and mix with blood, the moment water comes in, the blood and water mix together. So that is it, and we have been using it, and I saw a publication in the literature also about it. We have not published it. So I think
should be comparatively safe in the LV dysfunction.
Dr. Ziad, you have
any comments on that, Dr. Ziad?
Sure. So there are a few downsides to dextran which should be recognized. There's approximately 1 in 1,000 risk of anaphylaxis. The anaphylaxis, if it does occur with dextran, is very severe, and usually leads to ICU stay, intubation, and anaphylactic shock, because it's a preformed antibody response. The second problem with dextran is, as was mentioned, of course, is that it is high molecular weight, which is also the problem with contrast. So if you use a high molecular weight substance, you're basically using a high molecular weight substance like you're using contrast, which can also cause contrast nephropathy, although now we call that dextran nephropathy. So I've actually stopped using dextran. We were some of the first to use it and published fairly extensively on it. But now I have a very streamlined approach. When you have your patient and you're planning to do a PCI, I only take 3 angiograms. One eleocranial on the right, one epicranial, one epicaudal on your left. If you've identified a target lesion, the next picture should be with the OCT. Okay? Once you've got your next OCT, the OCT is now the CT scan of the artery. You can flip it inside out, upside down, look at it in any way you want, and do your procedural planning without requiring multiple views on your OCT, on angiography. In addition to that, in Illumian 3, which was a multi-center randomized controlled trial, including 30% diabetics, the total contrast volume difference was 30 milliliters, and there was no increase in renal failure. In fact, there was no episodes of renal failure in the entire trial. So the amount of contrast is really fairly negligible in terms of your renal risk, unless you're doing it in patients who have creatinines of 200 or 300. That may be more problematic.
So basically, you can, using less contrast, you can see most of the things what we expect to think. We'll move on. I will have a last question.
We'll have
the
to move
other
on.
thing that, with this 3D and MSS software, the picture is so clear. I just wonder what cases we will use IVS, except ostial, maybe when there is a patient with renal failure. Any other case, other than that, do you find anywhere IVS has a role?
In my practice, only 3 places: CTO, osteal, and very advanced chronic renal failure. Not on dialysis. That's it.
In left main sizing, that was a big issue because we both were doing yesterday 2 cases. I was left main bifurcation. He was doing, I was doing. I was using OCT. He was using IVS. A lot of discussion. What do you think with the ideal to do the sizing of the left main, OCT or IVS, if OCT, how?
So if you're using OCT to do the left main, the first thing you need to understand is that IVUS oversizes compared to OCT by 10%. So all of your cutoffs should be reduced by about 10%. So if the traditional cutoff is 6 millimeters squared, your OCT cutoff is going to be 5.4 millimeters squared. With regards to your stent sizing, it's all based on your reference vessel. So your reference segment should be sized to the circumflex in the circ and the LAD in the LAD. So, and then the expansion is based upon the reference segments in each of those cases.
It is when you talk diameter on the measure diameter in the left main, I think it's intima to intima, we get it from, which is something like intima to intima diameter OCT, and then odd quarter, that's the size. Is it some formula, is it there like that?
No,
You just measure directly according to the external lamina. You measure media to media by OCT. Directly, and then round down to your next closest stent size.
Actually, if I can just put in a few words, because we've been doing OCT for a long time. You see, intima on OCT will depend on how thick the lesion is. If the lesion is very thick, your intimal size would be nothing. So you have to size the vessel, and the vessel size is by media, the internal elastic lamina, and the media is very thin. So whether you measure the internal elastic lamina or external elastic lamina doesn't make much difference, but you have to measure from the media. So one. Second thing is, when is it that you will not be able to size the vessel with OCT? I think one has to understand, if it is an extensive lipid plaque, the lipid plaque will not let light go through, and that is the situation when you will not be able to see the 3-layer structure at all in case, and if you are doing left main, but there could be an issue. So that is where, to size the vessel, there is a possibility that IVUS might do it better for a localized left main disease. Otherwise, if you have a lot of normal segments up and down, then you can always size it. Left main is a very short vessel, so that is the so-called limitation, and you have a very heavily lipid-rich plaque. The third point, which could be theoretically said, is if the left main is more than 5 millimeter in size. Now the light has a penetration power, the OCT has a penetration power, to the best of my understanding, about 5 millimeters. So if your vessel size is bigger than that, then maybe it may not be able to see you the lamina. So that is that, but it is a beautiful picture that you get, and I always use it more for the final assessment, especially the distal dissections and prolapses and malappositions, where it is certainly much better than IVUS, but sizing for left main, I might prefer IVUS. That's it. Now, if we have a few words on FFR, because we need to wind up the FFR thing also. I think Dr. Ravi gave a good talk on FFR. So now the issue there, I think what we did a study on about 107 patients where we consecutively did FFRs on most of the intermediate lesions that would be there, 30 to 80%. And then sized and then decided on the outcome, on the whether to do or not to do. So what we found, in fact, is that a lot of cases, lesions would be both underestimated and overestimated. And based on that, what I have now realized, because as we saw some studies that he presented where visual assessment and then FFR assessment by a different operator. So there could be a lot of subjectivity in that angiographic assessment. If the lesions are very short, that is the one which catches your eye. You get the oculostenotic reflex, and which will be really oversized by angiogram, and FFR will give you the right assessment. You will not be able to oversize it. And several times on angiograms, when there is mild long segment narrowings, your eye will not make the oculostenotic reflex, and you will say it is mild, and that is where the FFR will tell you that it is significant and it needs to be done. So it converts both triple vessel disease into single vessel and single vessel into triple vessel, and gives you the right probably outcomes. So I think I use it in my practice for most intermediate lesions and FFR, and if you will do about 100 cases with FFR, you will soon realize your angiographic interpretation has become better. I think we just need to have a last talk. Dr. Ravinder Rao has come. He is going to tell us about the closure devices, so in place of Dr. George Joseph. So before we end, we can have Dr. Ravinder Rao there.
Good evening, everyone. Thank you very much, sir. I won't take too long. Ziad, how are you? Welcome to India. Thank you. Can I have the slides? So the talk is suture-mediated vessel closure. Let me begin by asking this question. How many in the audience do more than 50% of their interventions by femoral route? Just one hand. So, I mean, so more than 90% of the interventions are radial.
You should ask how many, after having done a femoral procedure, use closure devices or not.
So, yeah,
that is the right question.
Yeah.
So there might be people like me who might be using a closure device in 100% of femoral cases, although the femoral cases may be only 5% or 3%.
Fantastic. So how many in the audience, if you are doing a femoral puncture, you are doing a fluoro-guided femoral puncture? So none. So before I begin, the most important part is you should have a right puncture at the right site in order to make your vascular closure device successful. So this is ProGlide. Okay. So ProGlide is a suture-based vessel closure device, vessel closure system. There is a collagen-based, there is a foot plate, sealant-based, different types of closure devices which are available. But the one which I'll be talking about is a suture-mediated closure device. So this is the part of these device. You have a foot plate, you have a paddle, you have needles. I think you can always I'd like to put a video basically which is more explanatory and it's going to take less time. This is a knot pusher. You push the knots, and so So the most important thing in order to get your suture closure device correct is to have a correct puncture. It can only be used for a common femoral artery entry, and that too it has to be an anterior wall puncture. Because if you are in the profunda or superficial femoral artery, the foot plate of the proglide can close the vessel itself. And definitely the entry point should not have heavy calcification, because one important complication which can happen in these patients is the foot plate can lift a calcified plaque and can close the vessel. Sometimes the foot plate can also lift a plaque from the posterior wall and can close a vessel. So failure of the proglide, at the maximum you will have a hematoma, but if it closes the vessel, then we need to intervene and take care of that. So this is, you flush the proglide system. Can you play the video please?
All number is, sorry? All number? 2.01. Okay, so I'll just come. I'll come in 5-7 minutes, okay?
Okay. Because video is self-explanatory, so I thought we'll play a video here. Okay. Let's go to the slides.
Yeah, I think I have to switch into the slides.
So first step, once you have a correct puncture and you have a 6 French or 7 French sheath, you put the wire inside the sheath, remove the sheath, over the wire the proglide device goes in, and you'll be seeing a back bleed from the side port. Once the back bleeding is happening, that means you are inside the vessel. Then you deploy your foot plate and you pull back. Once you pull back, the bleeding from the side port should stop. That is very, very important. That tells you that the foot plate is against the anterior wall. Suppose the bleeding is still ongoing and you deploy your plunger, the needle will go through and through the posterior wall. So once the bleeding is stopped, you maintain that pull. And with maintaining the pull, then you push your plunger down. This is the plunger. Once you push the plunger down, the needles pierce the anterior wall, and then you pull it out and you cut the suture. Suture has got a blue and a white end. You cut on the blue end, then you open the foot plate and this comes out. You harvest your sutures and put the wire again. There is 2 white markers, and through the 2 white markers you put your wire again. And leaving the wire in place, you remove the proglide device. You will be left with 2 sutures. So you can imagine you have a crisscross, you have a sutures across the artery. The white portion is basically locks the knot. So you don't touch the white part. The blue part of the thread you pull. By pulling, you deliver the knot on top of the artery. It is by pulling and not by pushing. Sometimes what happens is that the tract has got a lot of subcutaneous tissue and the knot is not able to reach till the top of the artery. So there is a knot pusher. With that you can do gentle push and you try to reach to the top of the artery. Once the hemostasis is achieved, then if suppose the hemostasis is not achieved, you have a safety wire in place, you can put your sheath back again. But once there is no pulsatile flow, the sheath comes out, the wire comes out, you pull your blue portion, push the knot with a knot pusher, and once you pull the white thread, the knot gets locked. And then you can go ahead and cut it. The best part of using a suture-based closure device is, suppose you need to re-intervene in the same vessel, you can do it in the very next day. And a single proglide can be used up till 7 to 8 French sheath. But if you are going with a bigger sheath, you need to do a pre-close. That means you need to deploy the sutures before you put a bigger sheath. And up till 18 French sheath, we do 2 pre-close or 2 proglides, 2 pre-close with 2 proglides, and above 18 French we would prefer 3 proglides. So I think that should be enough. I wanted to show a video, but for some reason that is not playing. And maybe you can practice on some demo slides. But this is very, very useful. So now, I mean, everybody here and on the audience, most of you, if you are doing a PCI and if you have a common femoral artery puncture, again, very important to do a femoral angiogram before we go ahead and deploy the ProGlides, because you want to be sure that the entry point is in the common femoral artery. If the puncture is correct, if the site is correct, then most likely you will have a good closure. Thank you very much. I don't want to hold anybody long before.
Thank you, Dr. Rabindra Rao. I think with the TAVR becoming more and more popular, and then we are also using a lot of big sheath in all the aneurysms, and you should learn this pre-closure devices very well, because and you should start doing regularly, then only you can do
Yeah,
it.
I agree. This can be part of a
This should
PCI
be
also,
start.
yes.
You should start when you start up with the diagnostic, go over for the interventions, coronary, and then subsequently. But you have to do consecutively 15, 20 to get a hang of the things, so that you
Agreed,
can
agreed.
confidently do it.
Yeah, yeah.
So I think we are going to have more and more elderly people, more TAVR, more aneurysm, and more big sheath. So I think
More
this is
ProGlides.
very ProGlide is the in thing. I think we should learn everything. I think best is to start up with diagnostic, do consecutively 10, 15 cases, then you will be very confident. Thank you very much.
Thank you so much.
I think it was an excellent session. All the presenters, I thank all the presenters and participants. And Dr. Jihad Ali from USA spoke very well on the OCT. We had OCT, a lot of new things coming in. I think, thank you very much. Bye. Thank you so much, sir. Fine.
How are you, my friend?